is how informed the consent should be. For most of us, before surgery, the consent is a very important document. We get a printed form, we give it to the relatives, they sign it, and then we put it in the safe place. Most of the time, the surgery went well and there is no issue. However, sometimes, unfortunately, there is a complication. And at that point, when the patient goes into the court of law, the court asks us to give us the consent form. And at that particular point, that piece of paper become the valuable document. And very importantly, the judgment can be based on that. So many times we take it lightly, but it's very important to have it proper. To understand how informed the consent should be, we are really lucky to have two experts on the subject. The first expert is Professor Dr. Omprakash Nandimath, and the second one is our own orthopedic surgeon, the member of Pediatric Orthopaedic Society, Dr. Narsimha Rao from Trichy. So a brief introduction about our faculty. Professor Dr. Omprakash Nandimath is a professor at National Law School of India, Bangalore, the prestigious institute in the law education. He's there for more than 25 years. He has a special interest in medical law, accomplished author, and only yesterday his book on the medical law was published. He has been legal advisor to many government, national, and the state level panels to educate about the medical law and how should be the procedures. The second expert, Dr. Narsimha Rao, is orthopedic surgeon practicing in Trichy. In addition to orthopedic surgery, he has a keen interest in medical law, and he is a postgraduate diploma, and he carries out medical legal consultancy practice for last 6 years. Both the faculty have a keen interest to give autonomy to the medical specialty, and for that they are working on various projects, and one of them is informed consent. Just to give you the outline of the program, in the beginning we will have two talks, the first by Dr. Rao and second by Professor Nandimath. And after that, we will have a discussion for around 25 to 30 minutes. And that discussion will be moderated by Dr. Ramani Narasimhan, who is a past president of POSI. If you have any question, you can send to Dr. Sandeep Patwardhan on his mobile number 98230-63989. I repeat, 98230-63989. Before I hand over to Dr. Rao, a last word about the upcoming event. The next month, on the 9th March, exactly 4 weeks from today, we will be celebrating our 50th webinar. And for that, we are really fortunate to have the legend on the subject, that's a hip preservation surgery, breaking the rules. Professor Gans will be our faculty, and he will be enlightening us on his lifetime work on the hip preservation surgery. So with that, I stop sharing and I request Professor Rao, Dr. Rao, to take over.
So thank you very much, sir.
Yeah, just a minute. Yes, I hope you are able to see your presentation.
Yes, sir. So can we proceed?
Yeah, please.
Yeah, I'll try to keep within the time frame. If I'm overshooting, please let me know, sir. Yeah. So thank you very much, sir, for the kind introduction. So, dear friends, next, sir. Sir, next, can you move on? So, friends, the objective here is to facilitate the understand the philosophy of the what, why, and how of consent. in practice rather than expecting prescriptive solutions. So please move on. Please move on. We know we have a huge exponential growth in litigation, and it's a huge financial burden on us. So what do we do about it is what we are going to discuss here. So please move on, sir. A few clicks.
Yeah.
You can move on a few clicks. You can move on, sir.
Yeah.
So ignorance of law is not an excuse. And for us to understand the what and why of consent, we'll be looking at a few pertinent legal principles. Please move on to the next slide, sir. In which the pertinent definition of law which was taught to us in law school was that law is an instrument which protects an individual's autonomy over a person's personality, person, and property. And in this situation, go on, sir, please go on. Consent is one which respects the autonomy of a individual's autonomy over his personality. And personality, as we know, is a set of likes and dislikes of an individual. Clarity and precision in this regard is of utmost importance because violation would attract penalty under specific sections of the law. Friends, I would like to draw your attention to the second point under consent, which is when a patient alleges that the consent was not taken, the onus of proof is on the doctor. Whereas if a patient alleges that the treatment was not correct or there's medical negligence, it is up to the patient to prove it. So that is important. So that is one point we need to bear in mind. Please move on, sir. The next is the ABC of proving negligence, which is A is a duty of care that is owed by the doctor to the patient. The second is a breach of this duty should have happened. And third is there should have been a consequential damage. So to prove this breach of duty, please move on, sir. There has to be a standard of care that has been breached. Details we look into later. And there has to be a due diligence for the standard of care. And with regard to consent, it will be best if there is a uniformity or a model consent form to prove that there has been a standard of care and that there has been no breach of this duty. Next, sir. The next is, please hold on here, sir, for a moment. Yeah. We all know POP is our bread and butter. In law, there is another POP we need to understand, which is the preponderance of probability. To explain this concept, let me give you an example. Now, here was a sick patient who was taken to a hospital in Delhi called Gangaram Hospital. And this sick patient was there in the hospital for 2.5 days. The patient was not shifted to ICU. The patient was really sick because he was not in a position to be shifted even for a scan, sent to a scan or a ICU, and the patient eventually died. They went to court and the court said, the court was aghast that, you didn't even shift the patient to an ICU, and they were not willing to listen to other things about the patient condition. And they said that the hospital and the doctors were negligent. When the hospital and doctors went on appeal to the Delhi High Court, just one click, sir, please, one click. Here was a 4-judge bench in the High Court of Delhi, which actually counted the number of visits by the paramedical staff and the doctors, and they found it to be about 150 over the 2.5 days that the patient was there. So please look at this, friends, because see, the judge has no way of knowing what actually transpired on that day. So he tries to reconstruct what could have happened based on the narratives given by the patient and the doctor. So here the judge has gone by, or the bench of judges has gone by the documentation to show the due diligence by this team of doctors and paramedical staff. And they were not willing to go into the technicalities of ICU, no ICU or scan center. And the High Court actually said that this hospital and doctors were not negligent. So basically a preponderance of probability is a concept of evidence in a civil case or a civil litigation, not criminal. So this has to be borne in mind because this was on our minds when we drafted our own consent form. Please go on a few clicks, sir. So we have gone through a few of these concepts. Details we can always discuss in discussion based on the questions that come up. Please go on, sir. So with these concepts in mind, we did a small experiment. Please go on, sir. To go ahead, and we proposed a model consent form to address two aspects. One is to prevent litigation. Second is to fight litigation should the patient choose to litigate. Next. So this is what we have shared already to all the members of the society. You can always go through it and then ask questions in the discussion. So I'm just running through this to show some salient features of this so that we can have a discussion later on. So the first page shows who have been involved in drafting this and the clubs which have adopted this consent form to show the credibility and the uniformity. Please go on, sir. You can go on a few clicks, sir. So these are the details of the consent form which we have shown. Please go on, sir. You have this in your hand already, and every line in this consent form, we have gone through a rigorous process as guided by Professor Nandimath, and we have met a few times over a 14-month period, and we have come across and come to this, this format. Please go on, sir. And we have launched. Please go on, sir. A few clicks, 3-4 clicks, and we have launched this consent form to indirectly show the due diligence and a preponderance of probability in the favor of the doctor who has taken this consent form. And incidentally, it so happens that this consent form was launched exactly on the 9th of February 2019, 3 years ago. So please go on. So these are procedural guidelines. Yes, please go on, sir. 3 more clicks. There are a long list of complications, what we choose to mention, what we do not choose to mention. Again, it all depends upon a collective wisdom of the professionals who are in this. So that is why we are here. How best can we put our minds together and then come to a consensus as to what needs to be said and what need not be said. So this is going to be a long process, but we are here to just to understand the philosophy of it. Please go on, sir. So just as the best medical care is no guarantee for your cure, just like that, lengthiest consent is no guarantee against litigation. But then why are we here? Because we need to have a consensus. Please go on, sir. Please go on, sir. So rather than having a conflictory mode where we try to deny allegations and then, please go on, sir. A few clicks one by one, sequentially. And then we talk more of negligence and usually end up with adversarial judgment. We can talk of an inclusive method of approach where we talk of the diligent time, standard consent, and the standard of care, and thereby end up with a better equitable judgment in favor of, in the best interest of all concerned. Please go on, sir. So if we can have the legal and the medical people in sync with the law, please, we can have an adjudication which would be fast and also objective. Please. So if we can put our minds together and then try to see what best we can do when we have all the time, we can actually form our own consensus protocols by which we can do our self-regulation and we can plug the defects of subjectivity and thus deter the other non-medical bodies like the judiciary or the state from encroaching into our domain, and then so that we don't end up with firefighting or in this case water fighting later on. So I think this is a very good move by the Paediatric Orthopaedic Society where we try to engage legal experts to guide us in coming to consensus protocols, so that the point here is our aim is to respect the autonomy of the patient, and at the same time we want to retain the flexibility of our care so that we can give the best care to the patient. So I think that part has to be clearly understood. Our purpose of coming here together is not to give me one click solution or a 1-point solution or give me a prescriptive solution. If I get this consent form, am I 100% safe in the court of law? No. So what we are trying to understand is what the law is actually trying to tell us with regard to consent. And then we are trying to put our minds as medical professionals, engaging the legal academicians who have the best interests of the medical profession and the patient at heart, and then draft specific formats which will reflect or show the evidence of diligence, a positive preponderance of probability, so that a patient would not try to litigate seeing the diligence of the doctor. And even if he does litigate, we have a very strong objective evidence in hand to fight it successfully. So thank you very much, sir. I close there, and then we can take on more questions as we discuss.
Yes, thank you. We move on to the next lecture by Professor Nandimath.
Sir, thank you very much. And I just would like to start by saying it is great to be amidst such luminaries. And I have been assigned a very simple task by Dr. Narsim and Dr. Dhirain to explain the fundamental premise on which the consent operates as far as medical treatment is concerned. And I'm also aware of the fact that we are trying to harp upon taking up a possible task of preparing what you can say a standard format for your society, which is being capable of used by all of you. So I try to keep these two, points in my mind and try, to say few words in about 10 minutes or little less than that. That is in fact the allocated time for me. Well, Dr. Narsim has quite, elaborately expressed as to why consent becomes very important in the case of doctor trying to treat the patient. It is not for your society. It is not for anything, but every doctor in every single, scenario has to necessarily procure the consent of the patient before he treats the patient or before he starts his procedure. That you can take as a fundamental premise of law. But I would also say simultaneously, there are certain exceptional circumstances envisaged in law. I will not go to them right away because of paucity of time, and that is not required also. Like if it is a case of medical emergency, you don't require consent of the patient. Without consent also, you can treat. If it is a case of dairy handlers and those who are working in food industry, they can be subjected to a periodical examination, that is medical examination and treatment, without really waiting for their consent because they can create a health hazard. This is by virtue of law. The third scenario is if you are inmate, if you imagine an inmate in the prison, then he is under the wardenship of the prison warden. So he can be subjected by the prison warden to certain amount of medical examination and things like that, including treatment. At that time, that prisoner's consent doesn't really matter. So we generally refer to such instances, ladies and gentlemen, as exceptional circumstances. So barring those exceptional circumstances, and my earnest request to all of you is don't go by those exceptions. Although exceptions are very important, we can probably discuss about exceptions a little later or some other time. Barring those exceptions, it is mandatory or imperative for the doctor to seek the consent of the patient before he attempts to treat the patient. Now, let me put it in a very simple form. You imagine a doctor who treats the patient successfully. Mark my words. He treats the patient successfully, but without consent of the patient being obtained. The cured patient goes to the court and he alleges he has been cured of his morbid condition. He has been successfully treated, but that treatment was without his consent. Believe me, on the first count itself, you would be held liable. We don't go to the extent of finding whether you are diligent in treating or negligent in treating the patient. To put it very bluntly again, that is the criticality of consent when it comes to treating a patient if it is not an exceptional circumstance. This is one point you need to really understand. And to beat the entire jurisprudence on consent, I would like to divide consent into three parts. There are three kinds of consent, ladies and gentlemen. One is express oral consent. The second one is express written consent. And the third one is, we call it as implied consent. And there are many authors who try to really, divide it into only two, saying that express consent and implied consent. And in express consent, they go further and divide, oral as well as written. But I want to tell you, before explaining all the three, I don't really think I need to explain to such an elite group what is meant by implied consent, what is express oral consent, express written consent, etc. But law doesn't really mandate that in every situation or circumstances, you have to mandatorily go for written consent. But your ethical regulations, that is Medical Council of India ethical regulations, do use a very, very, very generic terminology and say, when you are operating upon the patient, when the treatment includes operation, according to me, operation is a very generic term. At that time, you have to necessarily go for written express consent. Other than that, what law requires is consent and not necessarily written consent. But I try to always lay down the proposition of law, or apply the proposition of law. While training doctor friends of mine, I say three things. Keep this as, the yardstick. If you are, anesthetizing the patient, be it general or otherwise, if you are anesthetizing the patient, please, go for a written consent. And number two, if your assessment tells you that this is going to be a problematic patient for you in the future because of his attitude or because of his temperament, then I always suggest, don't care about law or don't bother much about law, go for a written, express consent. And the number three, I also say, in case the treatment induces pain, it is going to be painful and it is going to be long drawn treatment. The best is, we advise, go for a written consent. So I have covered pretty much my first point, that is proposition of law is, unless it is a exceptional circumstances, consent plays a very, very critical role. So without consent, if you even treat the patient better, you would be held liable both under civil law and in some cases criminal law also. So it is the criticality of the consent which I have emphasized. Now, I also tell you, ladies and gentlemen, you must have heard, we talk about valid consent, informed consent, real consent. These are the three terms which you might have heard lawyers and law talking about, but they are all synonymous. I once again repeat, real consent, right? The second one is valid consent, and the third one is informed consent. All of them are synonymous. And law says it is not taking the signature of the patient on a dotted line. If you have done that, it is not a real consent because you have taken the patient for granted. So there is some amount of preparedness. There is some amount of information which you require to share with the patient before he is enabled to give consent, because only person with capacity can give consent, and the person who lacks that capacity cannot give consent. There are three inherent incapacities. One is if the person is minor, definitely he doesn't have a capacity, then you have to go by his parents or guardians' consent. The second, one is soundness of mind. If the person is unsound, at that time you again go by proxy consent. The third one is if you have a person who is unconscious, who is otherwise major and he is quite competent, of a sound mind, etc. But at that given point in time, he is unconscious, so you cannot really wait for his consent. At that time, you can, by proxy consent, go ahead. But other than that, if you have a patient who is not been provided with sufficient information, then the consent becomes vitiated. That is why informed consent or providing information to the patient before the consent is obtained becomes very important. That alone will make the consent real, valid, and workable. Otherwise, the consent is vitiated. Now, the very, very important question, multi-million-dollar question is, how much of information is said to be sufficient information? Every doctor, believe me, you would dabble with this, would have a problem in his mind. So he keeps on coming back to us. Believe me, you, many doctors do call me in critical conditions and ask me, sir, how much of information do you think I should be providing? Well, I don't want to get into theory because this is not the forum, nor I have the time. I always say in India, the Supreme Court has clearly said, laid down the principle. It says, let the doctor take a call because you are a professional. When it comes to you as a professional and me as a patient, like Dr. Dhiren, I go and consult him, and he is my professional man. At that time, I am surrendering to him. That is why law says, let Dr. Dhiren decide, depending upon my, what you call as inquisitiveness, appetite, and circumstances, how much of information would enable Professor Nandimath to independently decide whether to go ahead with the treatment or not. That is why all that information which is sufficient to make the patient enable to give, a valid consent is the parameter. That is why it is quite dynamic. That is why it is a dynamic parameter of law. One size doesn't fit at all. You may have one patient who may come to you and say, sir, you do whatever you want. Even you are attempting to explain to me what kind of a procedure you wanted to undertake. But I say, Dr. Dhiren, I have come to you. I know you are the best in India. You do whatever you want. I have completely, surrendered before you. Because I know whatever you do it for my interest. So it is one extreme category of patient. Another extreme category of patient I see nowadays, I have done so much of half-baked, what you can say, internet search by Googling. I have so much of questions, including, sir, according to the latest publication, there is 0.3% of, fatality that has been reported and recorded. Do you think I come under that 0.3%? Can you imagine how difficult it is for the doctor to answer that call? I hope you are getting my point. So that is why I am trying to say, it is not that easy for us to say what is sufficient information. You need to actually, depending upon the interest of the patient, you need to take a call. It has to be actually customized to every patient. That is what the Indian law is. Well, I don't want to go anything further because I had to respect not only the time that has been given to me, all others' time, ladies and gentlemen. I take another just 2 minutes with the permission of Dr. Dhiren. I just would like to say why we attempted to develop the standard format or printed format of, consent form. Well, if you really take, maybe when next time opportunity knocks my door, I would give you an elaborate picture as to why I am saying this. But right now, let me abruptly make a statement, if I'm permitted to do so. Dr. Dhiren, Dr. Narsim knows about this. Nearly 80% of the litigation today in India, because Dr. Narsim had one very interesting slide where he said there is already 400% increase as far as litigation against doctors. Right. This is a very, very conservative estimation. But my estimation is it has crossed 1,200% since the VP Shanta's judgment in 96. Be it as it may, I'm not on that. Nearly 80% of the litigation today between doctors and patients, one element of issue or one element of contention is always on consent. Either the doctor tries to duck under the consent saying that I have explained everything to the patient, but having consented, he has gone against me. Or patients try to rely saying that we were never told that such and such a procedure would be conducted against us, or we would be subjected to that kind of, let us say, process of, medicine and things like that. So the point I'm trying to say, nearly 80% of the cases, believe me, consent is a very important issue on which we try to litigate. That is why we said, can we have some kind of a gold standard created? And this gold standard will be created once there is acceptability by your community. But for that, we can't really wait every single doctor in India to come and subscribe to our format. We needed to take the first step. Like the journey of 10,000 miles also starts with the first very baby step. So we have taken the first baby step and created, for Orthopaedic Society, we created this. Believe me, every stage, every punctuation mark, he was saying every word. Dr. Narasimha, to repeat his sentence, he said every word and every sentence we had some kind of a threadbare discussion. I add further, I go one step further and say not even that, even punctuation marks, doctors used us as a punching bags. They had a lot of challenges, why I had to write like that, why I can't write differently. Then we justified our stand. With that, kind of a distilled effort, we could able to put that. And if that sort of an attempt is repeated to different sort of disciplines, naturally that would become a gold standard because of its acceptability and popularity. And with that, if not 100%, nearly 50 to 60% of the litigation or the chance of litigation, even in inevitable litigation, the chance of doctor being held responsible under the count of consent is drastically reduced. That's the whole point. And that is why this is a very, very critical or important forum where we are breaking ice together. I'm trying to conceptually try to say what is, probably going to unveil before you if you hop on to our, what you call as a bandwagon. If you decided to travel the journey with us, where you are going to reach is what I wanted to say. So this is, at this moment in time, I would be too happy and feel privileged to take any questions that may be thrown to me. But before I hand over the baton to Dr. Dhiren, I just would like to thank you profusely for giving this wonderful opportunity to me, sir. I feel completely beholden to you as well as your society for this great opportunity. Thank you, sir.
Yeah, thank you, sir, for a wonderful elaboration on the subject, giving us a basic idea about why we need consent and how much to write in the consent. I'm sure Dr. Ramani would have a lot of questions because this is a one topic where everyone has a lot of confusion, lot of questions. So I request Dr. Ramani to conduct the questions and answers.
Thank you very much. Thank you very much, Dhiren. It was a pleasure being invited to a kind of a non-conventional pediatric orthopedic webinar. So I am enjoying myself. I enjoyed the talks of both Dr. Narsimha Rao and Dr. Nandimath. Now, Dr. Narsimha Rao, in his talk, he emphasized on the importance of documentation. I think we all agree the documentation is so very important. Even in a case sheet, you have to put the date and the time and document the progress, and that goes a long way in protecting a doctor if at all there is a litigation in the future. And Dr. Nandimath has talked about the importance of proper communication. I mean, that is probably the most important part of an informed consent. And I think we all agree on that. Now, I'm going to be, there are so many questions. I'm going to be a little, be specific on certain points. Now, I heard Dr. Nandimath talking about anesthesia. Now, whenever we take consent, the consent is not just for surgery or a procedure, it's also for the anesthesia. Now, I'm sure every hospital, everybody has a consent for surgery and a consent for anesthesia, right? The anesthetist is supposed to come there, or the person who is giving or the administering the anesthesia, or the team, they come and take the consent for anesthesia. The surgeon takes the consent for the surgery. The patient invariably is under the primary surgeon, the pediatric orthopedic surgeon. Now, with the to you both legal advisors, I want to put forward to both of you that what is the impact of a possible, God forbid, an anesthetic complication on the admitting surgeon. Now, can Dr. Narsimha Rao take this first?
Yeah. So with regard to your point is whether we should take an anesthesia consent specifically, or what was the question again, sir?
So first of all, you please tell me, because I'm in Apollo Hospital. We have a consent for surgery, a consent for anesthesia separately.
Okay.
But the patient is under an admitting surgeon. I am the pediatric orthopedic surgeon. The patient is under me.
Yes.
So what I'm asking you very specifically is, even though we are all working as a team, both the surgeon and anesthetist, but in terms of a medical legal lawsuit, what is the impact of a possible anesthetic complication on the admitting surgeon? I mean, how does, because you see right now, the anesthetist is not in the picture in most of the places. He is always away from the whole scenario. He is never, the patient is never admitted under an anesthetist, right? And you do agree. So I'm asking you very clearly, because the anesthetist has a very important role to play in a major surgery where a general anesthesia is given, or for that matter, any dissociative anesthesia is given where a complication can occur. So what is the impact of an anesthetic complication, which we as surgeons, as a medical fraternity, we can differentiate between the two. But what is the impact of that on the admitting surgeon?
Yeah. Can I answer, sir?
Yeah.
Yeah. So in the model consent form that we drafted, if you have a look at it, we have actually included the clause for anesthesia also in that model consent form for any elective procedure. In fact, the point that you raised, we had a very detailed discussion on that also. What we decided was that, you are the admitting surgeon. So I'm the admitting surgeon. So I'm the captain of the ship. So I take the prime responsibility for this patient's care from admission to discharge, notwithstanding the fact that there are many multiple co-specialists coming in to treat. But I continue to remain the captain of the ship. So having said that, we include specific clauses to say that, this is the team of doctors. And after I answer this question, before I get the next question, let me bring to you the model consent form, which I got drafted today for today's surgery. I'll show it to you here, how I got it done. So the team of doctors sign it at the bottom and I fill the consent form. I'll just show you the one I got it today to explain what exactly I said. So with regard to getting the consent, yes, the anesthesiologist also signs it. And then in case there's a problem with the anesthesia, let us say the patient suffers a complication due to anesthesia, the point I would like to make is twofold here. One is the law, or we all understand as medical professionals, and the law also understands that, Narsimha Rao is trained to treat this particular aspect of the problem. And whereas there's another specialist, say Dr. Anand, the anesthesiologist, he's supposed to treat this part. So when the problem is specific to that, obviously he's going to answer. That is one. The second thing is, there was one case which was a landmark judgment, which was awarded 11 crores, which is the Kunal Saha case in the Supreme Court. Most of us harp on the negligence, medical negligence part of it. That lady had the skin problem and then she went on to become sick and then she was shifted to Bombay and then she died. So people talk about what medicine was given, dosage was given, and then negligence part and so on. But reading the judgment in detail, because of thanks to Professor Nandimath, who said, look at other aspects of the judgment, not just the medical negligence part. The compensation had two parts. One was pecuniary, which is the compensation, the monetary compensation. The second part is punitive. Punitive refers to compensation given as a punishment to deter certain types of behavior or attitude. And in this particular judgment, if you see, the judge uses very strong terms in the sense, here was a team of doctors who tried to shift the blame from one to another. There were 4 doctors who are implicated. The senior doctor tried to shift the blame to the junior doctor, and the junior tried to shift to the next one, and so on and so forth. So the judge took cognizance of this shifting of blames and said, the judge or the court abhors such behavior. And if your doctors are behaving like this in a court of law, I can imagine what you would have done on the patient side. So what I'm trying to say here is, let us not get worried about, who are all the specialists. So is it his problem or my problem? We all are dedicated towards a patient care. And when we take up as a position of standard of the captain of the ship, we say, yes, I take charge. And this is my standard of care with regard to pediatric orthopedics. And, this is my professional colleague who's also experienced person who's taking care of anesthesia. We feel sad that there has been a problem with anesthesia, and yes, he is here to explain the problem. I'll not say it is up to him.
Dr. Narsimha Rao, I'm going to stop you here. We take your points. Yeah. I'm going to shift this question to Dr. Nandimath. Yeah. I'm asking Dr. Nandimath that, unfortunately or fortunately, the surgeon is he is responsible. I'm talking in terms of legalities. The surgeon is responsible. The patient dies or has a serious complication, it has a long-term repercussions on the patient. The patient sues he doesn't sue anybody else. He sues the doctor. He sues the surgeon. The surgeon, how does the surgeon respond? How does the whole team respond? Because he's going to take the brunt of the whole problem. I mean, any kind of a punishment or a monetary this thing, everything is going to fall on the surgeon. So I just want you to be very specific in your answer. What I'm asking is something which we face day to day in our day-to-day practice.
Okay. Doctor, if you permit me just 2 minutes, I would say point number one.
Yeah.
This dual consent, one for anesthesiology and the second one for surgery, was not at all in vogue. This is not from the beginning. It actually crept in. And I call it as, let me very candidly put it, because there are some lawyer friends of mine, like among your community, even in lawyers community also, there are divisions. But I always say it is an aberration that was, whether it got created because of the, limited knowledge of lawyers or doctors, I do not know. This has, crept in between. Earlier, it was not there.
So is it good or bad?
It is, according to me, bad. Because what I'm trying to say, look here, in Indian Society of Anesthesiology, they are dead against me because of this, sort of an advocacy. They say, it gives us some kind of a professional status, that they are equivalent to surgeon. See, that may be your sort of fight for libido. But tomorrow, even nursing staff or nursing council will say, we will also take one more consent. See, you are only making it complicated and make the whole, package of treatment. See, when patient is treated, Dr. Ramani, you can treat me or group of doctors treat me, right? But ultimately, it is patient-centric. So, if there is no team head who is ultimately going to coordinate the efforts, it looks like fragmented sort of an approach, and it creates a basic confusion in the mind of the court, is what I'm advocating from the day one. See, this is one point. I don't want to unnecessarily go further and try to distort whatever I have said. So this is point number one. I am never, ever in favor of this two, what you call as consents or dual or many consents being taken, because you are talking of only one doctor and one patient. And on the behalf of that is behind that particular doctor, that is captain of the ship theory, what Narsimha Rao propounded, he has his own team of people. And he is responsible to coordinate the efforts of those, doctors. This is one point, doctor. But coming to the second point, Dr. Ramani, today, let us say if I go to a hospital, that is where these type of scenarios, like you said you work in Apollo. I have gone to Apollo and got myself the treatment and I'm not happy. Let's say I'm disgruntled. At that time, this particular question of two, consent forms, trying to hold the doctor and the complication arising from anesthesiology, etc., doesn't come. Because I will try to make the hospital as a first party. And I would make the surgeon, that is leading surgeon, under whose headship I am undergoing the treatment, as second party. And anesthesiologist also or anesthetist also, I may make him as a third party. And some 4/5, so many people, I may make them like administrator, board of the hospital, etc. That is what the lawyers will take care. And when the case opens, let me put it very, very simply, the law will try to find whether on all counts, be it with regard to anesthesia, be it with regard to conduct of surgery, be it with regard to post-operational care. Whether all standard of care was provided, that is standard of care was provided to the patient or not, is what court tries to find out. At that time, they come to know, let's say it is anesthesiologist who has erred. Because of that, let's say there is a mishap. They will not try to really hold the anesthesiologist responsible. They will try to hold the hospital responsible. But it is left to the hospital to recover it from anesthesiologist.
Okay.
You get my point. So it is not like mathematics, sir. So you need to really understand. But if you take some, gross errors, like, he has, the patient is put on general anesthesia, and in the middle of the surgery, he wakes up. And thereby it leads to so much of complication. So anybody can really say this is because of the error on the part of anesthesiologist.
So it is whether the negligence in terms of
Yes.
that particular personnel, or is it a regular complication? Yeah, point taken. And I really appreciate the way you responded, both of you. So Dr. Sandeep has a point. Is it pertaining to this, Sandeep? This particular thing?
It's a different question.
No, let us see. We'll just go. I think we'll just go through a flow, because I wanted to. Why don't you just ask the question? No problem. Go ahead.
Okay. So, to Dr. Nandimath and Dr. Narasimhan, my question was: since we deal with children, what constitutes the temporal validity of a consent taken for a minor? We treat a lot of children between 12 and 16 who are so-called adolescents, who technically can be called young adults and are knowledgeable and can understand what's happening. But the consent is still given by their parent. And if there is a complication for which their parent has consented, after 5 years, can they still pull you up saying that I never consented for this?
Yeah, can I?
Yeah, go ahead. Go ahead.
Yeah.
Narsimha Rao.
So the thing is, to my knowledge, Nandimath sir can correct me if I'm wrong. To my knowledge, when a kid is under 12 years of age, the kid need not sign at all. It is only the guardians or the parents who need to sign. So between 12 to 18 years of age, the kid and the guardian or the parents will have to sign. And beyond 18 years of age, it's the adult who signs. The witness may or may not be there. That's the point. Now coming to the next part of whether the temporal part of how long they can still sue us. See, according to our our code of ethics of 2002, it says 3 years your treatment records have to be kept. 3 years. But I would suggest, going by the precedents in the courts of law that judges have heard, that your physical record may be kept for 3 or 5 years that you would like to keep, but try to keep a soft copy of it. Scan it and keep a soft copy for life, because in a court of law, there is a clause called condonation of delay. That is beyond the period of the limitation period they call, that you have to sue between that 3 years. If it exceeds that, they have something called condonation of delay. And given a child, as you rightly said, a kid need not know what is happening to him when he was 11 or maybe 12 years of age. Maybe 9 years later, when he's 21, he would like to ask questions. So at that point in time, since we have the technology, why don't we keep a scanned copy of all your treatment records in a CD or somewhere and keep it safe? If in case there's an issue, you can always take it up. I would like to hear Nandimath sir's inputs on this.
Yeah.
Sir, thank you very much. And I would add to what Dr. Narsimha Rao has said. Dr. Sandeep, thank you very much for that question. Because you deal with children, okay, regarding the procedure, Dr. Narsim is correct that if it is less than 12 years, then you go by the parents or the guardian's consent and the signature of the child is not taken. But from 12 to, let's say, 18 years, you make the child also a co-signatory along with the parents, just to be abundantly cautious. That's all. But any which ways, in India, till the person completes the age of 18, his parents can give consent. And here I wanted to actually harp upon another very important, Dr. Sandeep, Dr. Ramani, Dr. Dhiren, please bail me out. I would like to reveal you a very important secret about the law, which unfortunately most of us miss. See, what law says is you should have treated the person after obtaining the consent. That's all. That is the requirement of law. But we try to assign more or greater importance to consent than that. In other words, you think, oh, I have said while taking consent that there is a possibility of post-operation complications. See, while procuring, I have really told the kid or the parents saying that this is one of the possible offshoots or one of the possible complications. But that complication actually occurs. But this doesn't mean, oh, you can duck under the consent because already you have explained the complication and that complication has happened. So he cannot complain about this.
Understood.
Because see, what I'm trying to say is, sir, Dr. Ramani sir, this is often we miss. We think consent is going to be a comprehensive contract of medical service between patient and the doctor. It is not. It is only to say, I touched the body of the patient after procuring the valid consent. That's all. Once you show that the value of consent, validity of consent, complications of the consent is over, then independently court and law will look into what you have done is proper or not proper according to the protocol or not. If it is not according to the protocol, definitely you are going to be held liable.
Dr. Nandimath, I'll take this one step further.
Yeah.
Now, all of us, they face a dilemma. The dilemma is always that, one of the complications always in any surgery, especially with general anesthesia, is death. So what is the best way to convey death as a possible complication? What do you feel?
Sir, I'll just take one more minute, if you permit me. Yeah. And you have all the liberty to stop me if you think I'm digressing, which teachers are popularly known for, right? So I always say this, doctor. If you let me first point is, suppose you have made it very clear because I am the patient. Let's take me. I have come to you and I have to undergo a surgery. At that time, you say, because you are undergoing surgery under general anesthesia, sir, there is a chance of fatality or there is a chance of you not recovering at all. Okay, you have explained this to me. And after knowing as that is the ultimate consequence or ultimate possible consequence, I put my signature and undergo and I don't come back. Do you really think you are protected because you have divulged that information and death has taken place? Can you take it as a defense? I always say the answer is no. This is the point most of the time doctors miss.
No, because, Dr. Nandimath, sorry to interrupt. What I'm saying is you're taking the other aspect of the whole thing. I'm saying whether we
1 minute, sir. Why I'm saying, saying this is because Dr. Sandeep was trying to, I was partly trying to answer Dr. Sandeep's question. That is why I said, look, whether it is 12 year below or 12 year to 18 years, you take his signature or only parents and guardian signatures are taken, irrespective of the fact, if you have acted upon a consent, I don't really think you would face any complications only on the count of consent. That is one point I'm trying to say. I hope, Dr. Sandeep, you are getting my point. The second point I wanted to add to Dr. Narasimhan as an answer to Dr. Sandeep's question is, there is a concept called competent minor or Gillick competency. This is a jurisprudence which has developed, very well developed in the West. There they say, because of the maturity, the kid develops some kind of independence. Maybe at the age of 15, age of 16, I always give the example, Virat Kohli. He started playing at the national circuit at the age of 15. Let's say at that time he consults the doctor quite independently. Do you still say you bring your parents? If it is West, there they say, if you are convinced that the minor is independent, minor has matured enough, then only on his consent, either you can go ahead with the treatment, or if there is a conflict between his parents and that competent minor, you can decline treating the, what you call as patient. But let me tell you, it is in, West, but not in India. So what is the situation or scenario in India? I always say that is only a theoretical discussion, because if you have a able body, he's like an athlete of 17 years age. His parents want him to undergo a surgery, but he is saying, no, I don't want it to, get treated done. At that time, when the patient himself is not cooperating, will you go ahead from a management point of view? It is not just, law. It is more than anything else. It is a medical decision. But if I have put the law in a fluidic situation, I can't help you, doctor, because this is how the law has, stops it in India. Now I will come to Dr. Ramani's question. How do you communicate? Law doesn't really say that. You need to develop that art of communication. Suppose, look here, I always, in my workshops, I always try to take this as an example. Dr. Narsimha Rao knows about it. You say, according to the, total statistics or whatever way, sophisticated way you put it, you say, sir, there is a 30% chance of death. The patient asks the doctor, sir, what is meant by 30% death? I know only either I am dead or I am alive. What is this 30% death? Can you explain? Then you explain, no, sir. There are 100 people who have undergone the same surgery. 30 did not recover. Only, 70 have recovered. Then he asks, okay, doctor, then you just give me your assessment, whether I fall in that 30% or 70%. Then I will take a call whether to go ahead or not. See, that is why communication is very, very important. How you communicate.
Dr. Nandimath, I'll interrupt you here.
Yeah.
Let me rephrase my question. I am asking you, first of all, do you think it is mandatory for each one of us to be mentioning death in an informed consent? That is the first question.
The answer is very simple. No, because I have already made it very clear. Every patient requires a different packet of information to be provided to him. You get my point? See, because the appetite of every patient is different. That is what we call as English approach or English professional doctors, reasonable doctors approach. In America, I would have said it is necessary, because American approach is quite different. They say, if you take a procedure, X is a procedure, these all are, information which you have to mandatorily provide to the patient, whether he is interested, not interested. It is like your air hostess trying to give, specific safety instructions, whether you are interested or not. So but in England, they say, let the doctor decide. And in India, we have adopted the English approach by Supreme Court. Okay. So it is entirely up to you.
I'll take this question to Dr. Narsimha Rao. What do you feel about you being an orthopedic surgeon yourself? What do you feel about my question?
Yes. So I will just try to substantiate what Professor Nandimath just said. To add to what he just said, that the approach is different in the USA and in UK. Let me read out, as you asked the question, I just took out a small excerpt from a landmark judgment on consent from the Supreme Court, and the case is Samira Kohli's case. If you give me a minute, I'll just read the relevant part to what you just asked. He says, this Justice Ravindran just says, in advising, and this is a gynec case, so in that context, in advising an operation, the doctor will take into account the personality of the patient and the importance of the operation to her future well-being. It may be a good practice not to warn a very nervous patient of any possible complications if she requires immediate surgery, say, for a malignant condition. The doctor must decide how much to say to her, taking into account his assessment of her personality and the questions she asks in view of how much she understands. If the patient asks a direct question, she must be given a truthful answer. Now he goes on to give an example. To take the example of hysterectomy, although the surgeon will tell the patient that it is proposed to remove her uterus and perhaps her ovaries and describe what that will mean for her future well-being, which is sterility, premature menopause. She will not be warned. She will not be warned of the possibility of damage to the ureter, vesicovaginal fistula, fatal hemorrhage, or anesthetic death. She will not be warned.
All right. So yeah.
Let me finish. So let me
Understood.
finish.
Yeah,
So
yeah.
let
Go
me
ahead.
finish. So this is what Professor was trying to say, that our approach is the English approach, which legally it is called as prudent doctor test. Here, the law feels that the doctor is more prudent than the patient, whereas in US they feel it is the prudent patient test. There they feel the patient is more prudent and he's got the right to access to all the information that is possible. Now, coming to consolidate to our purpose of meeting here is because we have gone through this exercise with Professor over 1.5 years. What I would suggest is, when you take specific pediatric orthopedic conditions and you want to format specific, consent forms, in your collective wisdom.
Mind you, Dr. Narasimha Rao, suppose we are dealing with a 6-year-old boy, and his grandparents and parents are standing in front of you. Now, this is the scenario.
So that's what I'm trying to come to, sir. So let us say you have a format created, for a specific pediatric orthopedic condition, and the collective wisdom of Pediatric Orthopedic Society of India feels in this particular condition, we might as well mention death also as a part of the complication. You mention it. So, and in another condition, you feel it becomes too superfluous to talk about death. Don't mention it. So you have specific consensus consent forms, 2 protocols. And
understood.
This is the consent form that will be distributed to all the pediatric orthopedic surgeons of India.
Right.
So that whether it is Narasimha Rao here following it, or Dr. Dhiran following it in his place, or Delhi you are following it, we are all following the same practice.
So what you are saying is the discretion lies with the doctor, and he has to weigh the situation depending upon the condition he is treating and the nervousness and the temperament of the family. Is that correct?
That is point number 1.
Yes.
And point number 2, we are taking this one more step further in saying, we have put our collective wisdom to it. We have taken the legal expertise on it, and we have come to consensus protocols, consensus forms or standard forms, which we are all following. That gives a lot of weightage in a court of law that, these diligent professionals have come together and formed something in a court of law, and consent becomes really strong. Thereafter, as Professor said, all your energy will have to be focused on your standard of care. Do not worry about the consent thereafter. Once we have put efforts in formulating a proper consensus form and you got it done as per our consensus.
But that comes later once the litigation occurs. Here we are trying to prevent one.
Correct.
So okay. So we are now, let me go to the next, some other different scenario. A teaching hospital.
Yeah.
We have residents, trainees with us. Now when we go as a team, you say you want your trainee to learn something, right? Under the guidance of the primary consultant. Is it mandatory for us to tell the patient that I have a trainee with us? And this actually, it's also, it goes more strongly towards free patients. I'm sure all of us, we understand, because you have a tendency that in a free patient, you allow subconsciously your trainee to have a freer hand. Okay. So forget about whether it's a free patient or a paid patient. Now, is it mandatory for us to be informing the patient or the family, we deal with children, that we have residents who will be involved in the surgery or the procedure? So is it mandatory for us to tell them that we work as a team? Is that how? And if they say no resident should touch me, only the main senior consultant should touch me, is that kind of a consent we need to tell them and take the consent? That is what I'm asking. Are you getting my question?
Yeah. So coming back again, the same thing where we started. When we talk about the captain of the ship being in charge, you explain, and then you say we are a team of doctors treating you. So beyond this point, I think Nandimath sir can add to this once I complete. I think beyond this point, again, it is the doctor's discretion to decide which is a patient where the next generation can be safely trained without any risk to the patient, knowing that you have the watchful eye on the resident, or which is the patient where the resident should just watch and you should operate. I think beyond a point, that discretion has to come in so that the next generation gets successfully trained with no risk to the patient. So that is
Dr. Narasimha, you didn't get my point. My point is, when we are talking about surgery, we are deciding that yes, the resident will probably take over. Do we have to inform that to the patient, or is it okay that, because I'm going to be there, so the resident is going to perform a surgery? Suppose we are talking about an implant removal, okay? God forbid, if everything goes smoothly, nobody is going to say anything. If a resident performs an implant removal and there is a complication, there is an excessive bleeding, the patient has morbidity, and then, then in the course of the legal procedures, it comes to light that the resident actually was in the picture. He was not scrubbed. He is around, but the primary consultant, I'm giving you a specific scenario. The primary consultant was not scrubbed. So retrospectively, will the court tell me that you should have taken a consent from the patient that, the resident will be involved in the surgery? This is what I'm talking about.
Can I answer this in two parts?
Yeah.
The first part is, again, depending upon the patient's personality, how much he can understand, how much he can understand or, accept what you say or do. So that you have to decide. It's not that all patients will expect you to tell everything, who is going to operate, the names or the list of people. So that you need to decide, number one. The second point is, in case of an excessive bleed, the court is more interested in checking whether you have followed the standard protocol in case there's a bleed happens. In case you are able to prove that, there is a bleed which has happened, even if I was doing it, the same thing would have happened. I immediately scrubbed in and I tried to achieve hemostasis and I could not. And the patient died. And you try to say that I am the captain of the ship, resident is no way connected. I mean, he is not at all liable. It is me that I'm taking the responsibility because I'm the captain of the ship. And I have done as per the standard of care. In this implant exit, I know there can be a possible complication like this. And then I intervened at the right time and I did my best. So that comes to standard of care. Now, just because you have told the patient that, a resident could be doing it, and then the resident has caused this problem, that will not save you from the standard of care that you have breached, if at all. So that is what Professor was saying.
So what you are telling me is, if all the protocol has been followed properly, then the cognizance will be taken of that fact that all the protocols were followed properly, in spite of the fact that the resident performed the surgery, but the primary consultant was around and supervising, and he was directing the whole flow. Is that okay?
Exactly, sir. See that. Let me just reiterate that point, that we should not confuse our standard of care and whether we have told a patient particularly something or not, because telling something to the patient does not give us the license to do anything we want in the operation theater. It is telling.
So Dr. Narasimha, why I ask this question is because I have worked in the US and lots of us have worked abroad. So there sometimes it is clearly told, because once they find out that the resident had been involved in the US, they can sue. They said that they can say that, you never asked me whether the resident would be involved in touching me and operating on me. So that is a very serious matter in the US. Let me tell you very clearly. So if in the Indian scenario, we are not bound to be communicating to the patient whether my resident is going to be involved or I am going to be involved directly, as long as I'm around and supervising the whole thing. So that's what you're telling me. So I'm going to put this question to Dr. Nandimath.
Sir, I will just because pretty much has been answered by Dr. Narasimhan.
Yeah, I think you agree. If you agree, that is good. That is good.
Yeah. Only thing is that is perfect.
So if a family, Dr. Nandimath, if a family is totally illiterate, if we have a total with low IQ, how do you propose that we handle them? This is the last question, Dr. Dhiren.
Okay. Yeah. Sir, I would only say, IQ, level would to a great extent, I would accept, but not, illiteracy or literacy, because generally law presumes. That is why when you are talking of a person's capacity, any person who is above the age of 18, we presume capacity, is it not? Unless it is proved otherwise. We don't talk about his literacy level at all. Because when it comes to my person, that is my body, my property, my reputation, law presumes every person has got some kind of a self-interest and he's capable of thinking very logically when his self-interest comes. So literacy goes out. Whether he is a literate or illiterate, you try to really assess the situation, and depending upon his appetite, custom make the information and provide it to him. This is what from the beginning consistently I'm saying. I don't really think I need to add anything. The second one is, if you're talking of IQ level, it's a generic expression, but I would say some people are, to use a commoner's language, is dumb. At that time, law says, if you spend little time with him, he is also capable of understanding, and that is more than sufficient. You need not have to do anything heroics than that. That's the simple, sort of a thing.
So it doesn't absolve you from the fact that, just because he has a low IQ or whatever you were saying, dumb, you could get away with any kind of a negligence.
No,
So that
because
is
you needed to respect his autonomy. Yeah.
Absolutely. So understood. And thank you very much, Dr. Nandimath and Dr. Narsimha Rao. It was a pleasure. I hand over to Dr. Dhiren.
Yeah, thank you very much. Over to Sandeep for summary of the session and vote of thanks.
Thank you, sir. Thank you. So as usual, it's been a brilliant an hour and 10 minutes of discussion. It's a very complex topic, I feel, but two things that I can take away from this webinar. The first thing that I understood is from Dr. Nandimath and Dr. Narasimhan is that consent does not absolve you of standard of care. It just implies right to treat and information given to patient. So just because you have explained all complications, it does not mean you can commit them and law will protect you. That is number one. It only gives you the right to treat that patient after having taken his permission. It's like a permission, that's all. So it is important that we put down things on paper correctly in the prescribed formats. And the prescribed format depends on need to know. And Supreme Court, fortunately in India, agrees to the fact that the surgeon is at his discretion able to choose and convey how much information he needs to share with his patient to achieve or get a valid consent. It is not mandatory to give each and every complication in the book to the patient and confuse or muddle the whole thing up. So you are perfectly competent as a surgeon to give selective, useful information which will allow him to make an informed choice without scaring him by giving all complications. Again, getting that consent does not absolve you, provided if you have to stand in a court of law, you will have to prove competent care and standard of practice which needs to be followed. And I think it behoves societies like ours, Dr. Dhiren and Dr. Ramani, to set those consensus statements and standards which can be followed across the country, because we live in India, so the jurisprudence will apply to people working in India. We need not worry about what happens in USA as long as Indian courts will accept it. So we need to create consensus statements for standard practices, good practices for pediatric orthopedics, and create consent forms so that they are standardized. And if a society does it, I'm sure Dr. Nandimath will agree, it carries more weight in the court of law than an individual making such forms. So with those few words, I thank Professor Nandimath and Dr. Narsimha Rao for this brilliant interaction. And I hope we can elaborate and highlight this further, and more people will take interest in this, because that is going to be the way of the future. So thank you very much and good night, gentlemen.
Thank you very much and good night. Thank you very much.
Thank you very much.
Thank you. Thank you, everyone.
Thank you very much.
Thank you.
Thank you.
Yes, now the recording has stopped, so we can chit chat.
Yeah, it's a complex thing.
Good. I think it's a very difficult topic, and still, like we need to learn a
Yeah.
lot about this.
Yeah. So what is important is that the law does not assume anything. As long as you have done reasonably good practices which are prescribed, there is no reason to get scared of anything, and decent paperwork should be there. It need not be your patient has to be a PhD or highly qualified or intelligent. Even rural people, when it comes to preservation of limb and life, they understand enough.
Yeah. And Dr. Rao, you mentioned about like giving the consent paper to the doctor, sorry, to the patient also.
Correct.
So that basically shows that you have not hide anything and you are like open in sharing the information. Is it what the purpose is?
Exactly. We didn't have the time, so I just brought this form,
Yeah.
which I take.
Yeah.
I write this personally. So
Yeah.
I write this in the original, and then there is a carbon sheet beneath this, and then the carbon copy of this I give it to the patient. So every clause in this was carefully drafted, and as you rightly pointed out, one of them is this, that the duplicate, there's a duplicate of this, and one of them is given to the patient on the day of signing it, and that the patient has received it. The point we are trying to show here is, there are many litigations in court where the patient says, I don't know what was there, and I think doctor has added something later on. That's one allegation that is made. So when we try to say that, on the day of signing, we have given actually a copy to the patient. That means the court, we are creating a evidence, a preponderance of probability that here is a doctor who was diligent enough to not just draft it, but was, very clear enough to give the paper or a copy to the patient, knowing clearly well that he can't tamper with it later on.
Yeah, that's true.
That's true. Yeah. Good point.
Right. Okay. I think we should work on this, Dhiren Bhai, more and continue this with the next set of our POSI executive body also.
Yeah.
Because eventually, with more and more as the years pass for the youngsters, they will require a standardized consent form and some standardized practices also, which
Do you
if
have a
they
minute?
follow those,
Yeah.
then they should be okay.
Do you have a minute more, sir?
Yeah, please.
Yeah. So there is one more clause, just like how you pointed out about this interesting clause. There's one more clause which says if there is a change in plan,
Yeah.
the patient has two options: whether he wants to come out of surgery, get a reconsent, and then go back, or he wants to depute someone on his behalf. It can be his closest relative or friend, to with who I can discuss and proceed to the change of plan or not. In the 3 years that I have put forward to all my patients, all the patients chose option B. None of them said, I'll come back and explain.
I
and
will
go
come
back.
out of surgery.
So why this becomes important is because the Samira Kohli case, which Professor Nandimath was referring to, this patient had undergone hysterectomy, though the consent was about a diagnostic laparoscopy or a laparotomy.
Okay.
It was an adhesive endometriosis. The assistant comes out, talks to the patient's mother. Mother says, go ahead with hysterectomy because the patient is already 45 years of age. The patient does well. Then she goes to court saying, they didn't tell me they are going to remove my uterus. And then they had expert gynecologists coming and saying, this is a condition where hysterectomy is the gold standard of care. And the judge very clearly says, the excerpt I read from, the judge very clearly commends the surgeon for a proper standard of care. He says, yes, you have done perfectly what needs to be done. However, this was done without her consent. Therefore, you need to pay a penalty. The doctor that is what Professor, without mentioning names, he said, even if the treatment is perfect, if the consent is deficient, the doctor is liable.
Yeah,
so
yeah.
because
so
of
you need not only a good result, you need good paperwork also.
So good paperwork before the surgery.
Yeah, before surgery.
So most of the medical legal experts in India now allude to this judgment and say, if there is a change in plan, please don't do anything unless it's an emergency. Please come out and go back as part 2, because that is what law tells. And here we are thinking about the patient's welfare. We see it is not fair to bring a patient out and go back in. So when I put forward, Professor, this point, it is against my conscience to come back out, but the law says so. What do you suggest? So he said, let us evolve. let us not wait for the law to hit us again. And then he says, let us throw the option to the patient beforehand, so that he does not get ideas later on from another advocate.
Yeah.
So throw the option to him. Do you want us to come out and go in, or you want to depute someone?
Yeah. That's
So he
good to
uses
mention
his right to
beforehand.
autonomy and says, I depute someone. So once he commits that he is deputing someone, he cannot go back to court and say, change of plan was not communicated to me.
Yeah.
So I think this is something which was, this was something which is really good.
Yeah. Excellent.
Really good, which is not discussed in most of the other, this one. I think it was just Professor Nandimath's brilliance.
Yeah.
And
Yes.
his team, yeah.
Great. Yeah.
Right.
Okay.
Yeah.
So-
Thank you. Thank you.
Thank you.
Sure, sir.
Good night.
Yeah. Good night.
Right, sir.
Yeah.
Good night, sir.
Bye. Bye.
Right, sir, bye.